Welcome to the Home Health Minute, your monthly podcast brought to you by the Home Health section of the American Physical Therapy Association. Hosted by Troy Mead. Hello and welcome to the Home Health Minute. I'm Troy Mead. Today we're talking to two of the therapists who helped develop the Incontinence Toolkit. This is yet another one of the resources that is available from the Home Health section. As always, for more information on how to download these resources, go to the Home Health section website at homehealthsection.org. Before we get started, I want to make you aware that the Home Health section is on Facebook and Twitter. Recently, there has been a lot of new developments in the home health environment that affect how we as healthcare professionals function in the future. Whether it's the new release of OASIS-D, the home health grouper model updates, or the return of pre-claim review, the easiest way to stay up to date is by following the Home Health section on Facebook and Twitter. Now with that said, I'm excited to share with you my discussion with Sarah Haag and Jamie Lowey. All right, so today I've asked Sarah Haag and Jamie Lowey to join me today to talk about incontinence. Hey, welcome both of you.
Thank you for having us.
Thank you. And for those who may not know you, Sarah, can you introduce yourself a little bit?
Sure. So I'm Sarah Haag. I work at a clinic called Entropy Physiotherapy and Wellness in Chicago. I work there with Sandy Hilton, and we kind of specialize in those things that nobody else, that a lot of other people don't want to deal with. So we specialize in pelvic health and complex chronic pain issues.
Jamie, I think everybody already knows who you are, but just in case someone doesn't know.
Well, I find that pretty shocking if they don't know me at this point, but I'm Jamie Lowey. I'm a home health physical therapist as my primary job, but I'm also a primary care physical therapist as well as a new venture I'm starting because I get to work in a clinic with a bunch of other really smart people, which makes me feel better. But I've been, for the last couple of years, gotten more into the idea that incontinence in particular in the home health arena is something that has not been addressed well and is something that physical therapists in particular are very well equipped in their training to be able to address if they get the right information and know how to apply it properly.
Interesting. So I had this one question. You hear it all the time, and it's maybe Jamie might be the best one to answer this.
Oh, I don't know about that. I'm not
Jamie,
the smartest one on the podcast.
So Jamie, incontinence is just a woman problem, right?
How honest we want to get? No, it's not just a woman problem. It is a human problem. And as such, it is not something that should be stereotyped into gender or age. It is, as Sarah is so fond of saying, it is not a normal part of aging. It is simply something that happens to people. It may be more common as we get older, but it's not a consequence of us getting older, and it is something that we can work on to correct.
I'm so proud and so amazed that someone actually listens to me sometimes. And I'll just pipe in that really, it is kind of usually relegated. Like if you watch the commercials on TV, it's always the ladies having the issues. And it is also more common with women, primarily because the difference in our pelvic floors and the fact that a lot of women end up having babies and a lot of those babies go through the pelvic floors. But if you look at as people age and depending on other comorbidities and things that can happen as life goes on, men do start to have incontinence more frequently. And if you start to look at quality of life, if you're a female, you're twice as likely to be admitted to a nursing home if you're incontinent than if you're not. But for the gentleman, you're almost 4 times more likely to be admitted to a nursing home if you are incontinent. So, that's something to think about is it as common? No, but is it maybe impacting those people who are in a pretty major way? Yeah.
So that kind of leads into my next question. So why should we be interested in incontinence as physical therapists or therapists in general?
Ooh, I'll jump into this one, Jamie, and then you can.
You're jumping at a bit, and this is right in your prime element. So you go for it.
Well, I was so excited when the home health section and like Sean Hagee and Dee Cornetti kind of was like, "Hey, this would apply to our population." I'm like, "Yeah, it would." Um, Mostly, it's for home health. If you look at the people who are receiving home health, often they're coming out of a hospital. Often they have a lot of comorbidities, um, and when you really start to look at the risk factors for having incontinence and the age groups and stuff like that, people who are receiving home health physical therapy, a lot of them are having incontinence. And that's just if you look at the stats. But then I started talking with home health therapists, and they're like, yeah, so you don't have to look at the stats. You just have to look in the hallway or in the closet or in the bathroom or, their chair. And incontinence is obviously an issue. So one, the population is primed for help, but also two, all of the interventions we have in physical therapy, and all the things we try to help people with, incontinence is one of those diagnoses that we have really good evidence that physical therapy can help improve it, that we can help cure it. And there's not many other things we have in our line of work that we can say we can cure. But once you get someone continent, you have cured their incontinence. And so it's a matter of, having the awareness and asking the right questions to be able to address the type of incontinence that person is having, and just coming up with that personalized plan that to address incontinence, just like we do to address balance deficits or strength deficits or other functional deficits.
Jimmy, did you have anything to add?
Oh, I always have something to add, but it's hard to follow that because that's in a nutshell what brought me into wanting to know more about incontinence. Just happened to be hearing a podcast from the Dustin Jones as he was interviewing both Sarah and Sean Hagee about incontinence and home health. And it was like a little kind of light went off over my head in the sense that the very next patient I saw was a gal who had fallen on her way to the bathroom and broken her hip. And as I asked more about that situation, she said, I get up 4 or 5 times a night, and I fell. And it dawned on me saying, I haven't done my job as a physical therapist coming into the home if I don't address that problem, because she may get better from her hip surgery, but she's still having to get up 4 or 5 times a night. And maybe it's only a matter of a few more months before she falls again and breaks maybe the same hip or the other hip. So I had that moment where it's like, I got to be able to do more than just a few weeks of interventions and say, see you next time, because I really don't want to see him a next time. And that's when I found there's a whole lot more stuff out there that I've not been doing as a home health physical therapist that has a lot more meaning to the people that I'm working with. It's one thing to be independent to go to the store. It's another thing to be able to independent to go out and go into a restaurant and not have to look for the bathroom, to know how far it is from your table in the restaurant to the bathroom, so you don't have to get up every, 20 minutes, and that's the course of your meal.
I like that. So you've already alluded to, this is something that we can make a big impact on. And Jamie started kind of alluding to what kind of impact it will make on our patients. So if I'm your average home health clinician out there, and I have the mindset, this is something that doesn't matter, this is something that I don't think I should be addressing, maybe this is for somebody else. What kind of outcomes or what kind of impact am I going to make on my patient if I start to incorporate some of this into my practice?
I'd say the potential is huge. I'd say it would be really fun to do a study, if maybe the home health section would be interested in that, is to look at the, long-term outcomes, really how big can the impact be. But I think if you ask someone, who is no longer needing diapers, who is able now to, like Jamie said, go to a restaurant and enjoy a meal, or go to the movies and not have their bladder or their bowels be the primary focus of their day, that would be a huge change in quality of life and options for enjoying life, which is really what we're about. We're not really about having people reach a certain gait speed, right? I mean, those are some of the outcomes we use, but we're trying to give them a better life, help them have a better life, better quality of life. So, I would say it would be huge. Jamie?
Yeah, and what I'll add on top of that for the home health physical therapist that oftentimes gets a lot of downward pressure from their clinical managers, even sometimes from the owners of the agencies, if it's a smaller agency, about what they're doing with their patients. Because right now, under the Medicare guidelines, cases that have therapy involved do reimburse higher. And while we don't always like to talk about the financial impact of what we do, these agencies are very much tuned into looking at those monthly income versus outflow of expenses. And having therapy involved in cases is where they do drive a lot of that revenue, because it does reimburse higher than if the case was just with nursing. So the home health therapist can look at it a couple of ways. A, you get to do some really important stuff with your patients. Give them back that independence that maybe they're really seeking out, to be able to be safe in their own home, to get up at 2 o'clock in the morning if they have to go to the bathroom or any time of the day, and not feel like they're going to have to rush to have an accident and then end up sliding headfirst into home plate and ending up back in the hospital. On the business side of it, from the agency standpoint, you're looking at not just adding therapy to their case mix, but you're also looking at a potential decrease in rehospitalizations, a decrease in preventable incidents like falls in the home, even potentially looking at urinary tract infections, because a lot of these people that are having incontinence don't drink enough during the daytime because they're worried about having to pee themselves all the time. So they stop drinking water. And as a result, their kidneys can have issues. They are more likely to get urinary tract infections. They have issues with constipation, which can kind of go both ways. So it creates a huge problem list for them, and they're all preventable. So why wouldn't you want to jump on that?
You make a strong case.
I hope so, because I think more of us should be doing this and not saying that's a nursing problem, or go see the urologist, or hey, it's toileting, therefore it's the occupational therapist. I mean, this is the person in front of you, and while it's great to collaborate with your fellow clinicians in the home setting, you can still, as a physical therapist, deal with this directly. And you don't have to delegate it off to someone else.
Well, and I'll pipe in here. So, so there's some people who think if you're going to get into this, well, I don't want to get into the pelvis. I don't want to do the pelvis. But honestly, in my opinion, and I'm sure there's some people who would totally disagree with me, is that this really is our business. So I am not a cardiac specialist physio, but I still need to know how to take a blood pressure. I still need to know how to screen things, and I need to know when to refer. And if I am with a patient who has an issue that is not something, even if it's in the scope of physical therapy, but not really in the scope of my skill set, it's really my job to go, I think you can get help for that. I am not the right person for that help. Let me give you my friend's number, or let me get you on so-and-so schedule. So you don't have to be a pelvic floor or women's health specialist to get into this. In fact, you don't even have to do anything directly to treat it. But I really do think if we're going to be these first line healthcare providers, if we're going to be seeing people from the community, it's our job to be able to identify these things and help if we can, but also refer if we can't / don't really wanna.
what point do we do the standing ovation part of this podcast?
I can add some sounds or something.
Okay. Because again, I think from a broader sense that point shouldn't be undersold in the sense that, I did do extra training. I did go to Entropy to learn more about the male pelvic in particular, and do some training that I did not get in PT school. And for some physical therapists, that may not be their comfort zone, and that's okay. I mean, as a home health physical therapist, the main reason why I bring gloves in my clinic bag is not so I can do an internal pelvic floor exam. Okay, but I have them, so if the opportunity is presented with, that would be something that the patient's agreeable to. If there's something that would be of benefit, then yeah, I have the training, but it's not required. I think just having the knowledge that this is not something common with older people in terms of part of the aging process, but that is something that can happen. It's kind of like talking in other instances about things like pain, in the sense that, yeah, it can happen, but there are a lot of reasons why. And it's not because you're old and have arthritis that you have it necessarily. And incontinence is kind of the same way. So providing education, letting them talk to a health professional about something that they may not have ever talked about before. And so I think some of the statistics that we have about the number of people in the country is probably an underestimation, because from my experience going into the homes, there are a lot more people that have it and have never told their doctor about it. They may not even told their family about it because it's too embarrassing. And it just takes the right question to ask in the right way, and all of a sudden, they're comfortable talking about it if you don't make it a stigma.
So you mentioned this before. So you both created the toolbox for the home health section with Ken Miller. Can you tell me a little bit more about that?
Yeah.
We can talk a lot about it, I think. So again, I'm going to defer momentarily to Sarah, just to say that while she may not say it, and while other people like Dee Cornetti and Ken have really kind of promoted the idea, for me at least, Sarah's been kind of the driving force behind this issue, to the point where she even joined the home health section, even though she's in a private practice, something that we might consider a mix between orthopedic and pain management and pelvic health. But she went ahead and joined the home health section, just because of how dedicated she is to getting this out to all areas of the physical therapy community. And you can't undersell that.
To be honest, I started hanging out with the home health folks, and you guys are a really, really fun group, but also really, really willing to go that extra mile literally for your patients. So no, it's been fun to be a part of that. And Jamie, thank you for your kind words, but I loved that there is the leadership in a section, and the section itself has been very, very open to this idea. I feel like to just do some more education. So the toolkit is just a collection of resources that it's free on the home health website, and it includes some basic information for therapists. So what is incontinence? What are the different types? How would I know what my patient has? So it has some questions. And so if you ask your patient, so when does this incontinence happen? And they're like, well, it's every time I stand up or every time I cough. It'll be like, oh, that sounds like stress incontinence. I would do something different for that. If they said, oh, it's only when I walk into the bathroom. Oh, that's urge incontinence. We do something different for that. Or I have a different list of questions. So Jamie made kind of a decision tree. So if you ask these questions, if it's a yes, you might want to look this direction. If it's a no, you might want to go this direction. And so you can actually use it in front of your patients. And so you do a little bit of reading, understand what incontinence is and why it matters. And then, okay, so these are questions I can ask. And I do think it's completely appropriate in, I always say, everyone should be talking about this. Really, if they come in with knee pain, I should ask them how their bladder is. Okay, maybe not. But in home health, I mean, it's on the Oasis. There's already you already have to ask. So if they say yes, you have some more helpful questions to figure out what you may be able to do to either help or, again, ask for help or refer a friend. Ken did a great list of medications. So there's tons of medications that impact how your bladder works, for better or for worse. Ironically, there's some medications that are for your bladder to make it work better, which sometimes makes it worse. So knowing that, wow, this is a limiting factor in their function, their ability to reintegrate into the community, and everything else is looking good, then that's worth a discussion with the physician or looking at how to best manage that. And there is a avoiding log. So while, there's an entire weekend course, which is actually a pretty good one, not one that I teach, on how to read and interpret avoiding log. But sometimes just having people keep track of what they're drinking and when they're going to the bathroom and when they're having trouble can really help anybody start to realize, oh, I'm going to the bathroom way more than I thought, or, I'm not drinking as much as I thought. And you can really start to identify small, achievable goals to see if that, again, impacts their bladder function. So there's a lot of good stuff in there, and I think each piece of it is pretty helpful on its own. What do you think, Jamie?
Oh, absolutely. In fact, just a bit about the part that Ken did, because he's not here to talk about it. For those that don't know Ken Miller, he also teaches a course on pharmacological interactions for another Con Ed group. So he's really well versed in the medications. And so what he pulled from is this thing called the Beers criteria. And the Beers criteria was an examination of the potential interactions and side effects of medications for older adults. So it's specific to the primary population that a home health physical therapist is going to see. So in addition to what this does for the toolkit, it's a great resource in general for home health physical therapists that may not be comfortable with their knowledge of medications. Because one of the things that sometimes they forget is you're part of a team. You have nurses who are versed in medications, and you have access to collaborate with resources that sometimes physical therapists don't always have access to. So it really helps facilitate the problem-solving approach, as well as that collaborative team approach to address a problem that might have just been otherwise swept under the rug. And we would have said, you've got your Depends and you've got your Flomax, so I guess that's all we can do for you. And, we'll work on something else like ankle pumps.
You brought it in this time, not me.
We got to throw that in. That's just for Cindy Kraft if she was. I also wanted to say just a little bit about the voiding log, because of all the things that I've taken into the home, this has probably been the most useful tool that I've had access to. Because what it does for me is unlike what I'd say a home exercise plan, this helps me put the patient in the driver's seat. They're doing the tracking. They're beginning to take ownership for the part that they can do, so that I can get a better sense of what life is like for them when I'm not there, versus them telling me, hey, yeah, I did my exercises or I went for a walk. This is an actual thing that we can then sit down and talk about that allows them to slowly take control of their life back, because then they begin to see what their habits are like. They begin to see, hey, you know what? I did have that glass of water at 9 o'clock at night, and then I'm up going to the bathroom at 11. So maybe I shouldn't have that glass of water so late, and see if that makes a difference. So that's where I really think this can be useful, is, again, it gets you thinking about how to solve the problem and not just kind of throwing a few exercises here and hope for the best.
A lot to think about. I do like how it addresses, like you said earlier, the home health clinician that may not be interested in specializing in pelvic health, but something that we should be addressing with all of our patients, by the Oasis itself, at least, and trying to make an improvement in quality of life. And I think that's like you said, that's what we're trying to do day in and day out is improve the quality of life of our patients, whether that's through incontinence, whether that's through sleep, whether that's through ankle pumps.
What don't ankle pumps make better?
I hear they're good for migraines too, I think.
Does your decision tree end in ankle pumps somewhere along the line, or?
It just might.
It just keeps circling back. Everything heads to ankle pumps. That or clam.
Here's the thing, Troy. You won't know unless you download the toolkit. It's kind of like one of those murder mysteries. You can't just jump to the end. You got to read the whole thing.
And there's no reason not to, because number one, it's free. And
it would be the fact that we do address constipation as well as bowel issues as well within the toolkit.
Besides the toolkit, are there any other resources that we should be looking for?
I'd honestly, you can head to Twitter a little bit more than Facebook. Is there on Twitter? There is the hashtag pelvic mafia. So if you're having questions or you're in an area you're like, I need help, but I don't know who to ask, you can either reach out to me directly. I'm happy to answer questions or try to connect you with people in your area. Or, you can just ask those questions via Twitter. And if you hashtag the pelvic mafia, you will probably get an answer. And again, if not, just email me or message me directly, because I'm happy to help and point you in the direction of the resource you need. There's tons of great resources out there that don't necessarily involve vaginal or rectal exams.
So I have to know a little bit more. Where did the hashtag pants not pads come from?
I think it came out. I'm honestly not 100% sure who to attribute it to, but the first podcast I did with Sean and Dustin, one of us said it, and it's pretty fantastic, I think.
It's awesome.
Because really,
I actually use that phrase with my patients. What our goal is? The goal is for you to wear pants, not pads.
Yeah.
And they're like, oh, okay, let's work on that. They're not usually that agreeable at first, because they're like, who is this weirdo talking about this when I want to work on getting my legs stronger? So don't worry, we'll get to ankle pumps in a moment. We might even throw in some seated marching and some long arc quads, but let's not get ahead of ourselves just yet. It might take 3 to 4 sessions to get there.
So is there anything else that we might be missing that you wanted to talk about?
Honestly, not me. Like, I'm just super excited that there's still interest and that the toolkit, I think it was, again, like Ken was the one who was like, we should do this. Jamie, Sarah, you're doing this. And it might have been voluntold by Dee. I can't recall. But yeah, just that it's getting out there. And I think that's such an amazing thing on a million levels.
Well, what I'd add on too is that one of the additional roles that Ken has given me, voluntold me is with the PT Now group, which is another kind of collaborative way to look at clinical practice guidelines between the sections. And so one of our goals with something like the Incontinence Toolkit is it does carry over into other sections within the professional association. It's not just home health, it's women's health. It is the Academy of Geriatrics. We could look at it in terms of even orthopedics, because, hey, guess what? The pelvis is an orthopedic structure. It's got bones, it's got muscles. So it could go into the neuro section even, because, hey, we got nerves going into the area. So it really takes the concept of physical therapy and takes us out of the dinner tray compartments that we tend to put ourselves into when we talk about, oh, I'm an orthopedic specialist, or I'm a neuro specialist, I'm a cardiac specialist. When the reality is something like incontinence can happen to any of us, and it does happen to a lot of people. So why would we want to sequester it into one section versus another when all patients are probably going to deal with it in one level or another in all of the sections?
Yeah, I have a slide in the course that I teach, which is pelvic health for non-pelvic health practitioners, which is basically if you're treating people, you are treating people who have incontinence. So just because you're not talking about it, just because you're not asking, just because they're not telling, this is it's a thing that's out there. So it's a thing with elite athletes. It's a thing with new moms, but also with people who haven't had children. It's a thing with gentlemen. And it's not, basically if your bladder is distressing you or distracting you from your daily life, there is help. And actually, if you don't have an active infection or cancer, PT is probably your best option to get better.
Excellent. Well, I appreciate all the work that you too and Ken as well has put into the resource, and I think it's wonderful. I think
I'll blush for Ken because he's not here.
Yeah. I think it's really helpful. I agree with everything you say. I think this is a place that, especially in physical therapy in general, but home health particularly, can really make an impact for our patients. So if anyone's interested, we'll put the links below in the podcast, of course, but you can go to the Home Health Section website at www.homehealthsection.org to learn more and get your own version, right?
Yep.
Excellent.
That'd be awesome. And both Sarah, myself, and Ken are always open to talking about this. And as the listeners will note, neither one of us is uncomfortable saying the word vagina or rectum. So, that's a conversation that needs to happen within the therapy community and within the therapists and their patients. So if they're not comfortable talking about it with their patients first, they can get comfortable talking to us about it and then take it out into the world. So there are a lot of us who are willing to mentor people who are not comfortable yet with the subject material. So definitely put out there, track us down. We'll be happy to talk about it.
Thank you for listening to the Home Health Minute, the podcast from the Home Health Section of the American Physical Therapy Association. Check out our website at www.homehealthsection.org. There you can find links to this episode, tons of helpful resources for your practice, and how to connect with us on social media. Thanks for joining us, and we'll see you next time.